All right, welcome back here on Live Impact News on WCNT Plus. I'm Nick Sertiver. So we want to head to Raleigh, where right now happening, and you can see this virtually, it's happening in person, but we want to take you there virtually, is a Joint Legislative Oversight Committee meeting on Medicaid. Now, this is happening at the North Carolina General Assembly. I just want to point out, this comes just a day after North Carolina Governor Josh Stein announced efforts to wipe out $6.5 billion in medical debt for 2.5 million people across the state. So let's take a listen in to what leaders are discussing there at the General Assembly.
COVID-19 pandemic, but H.R. 1 cuts federal contributions to the Medicaid program. It gets at federal cost drivers and reduces federal spending. It also limits state financing flexibilities that help the state bring in revenue for the program. And I'll point this out because Medicaid accounts for over half of all the federal funds that you receive in your state. It's 56% nationwide, according to the National Association of State Budget Officers. So that's a big chunk of change that will continue to decline out of the program in future years. And Medicaid is also countercyclical. What this means is that it's sensitive to economic conditions. When state economic conditions are strong, fewer people are enrolled in Medicaid, and the state brings in more revenue to account for those costs. When state economic conditions decline, what ends up happening is more people are enrolled in the Medicaid program at the same time that the state has less general fund revenue to account for those costs. So moving on to enrollment. What have been the trends in enrollment? Well, nationwide, states have seen declines in enrollment following unwinding from the COVID-19 pandemic, but they have seen increases in acuity. So how sick or healthy the individuals in your Medicaid program are. And as a result of that, many states nationwide are reporting increases in Medicaid managed care rates and costs to account for the acuity of the members in the program. And H.R. 1 introduces new eligibility limits, things that are likely to reduce the number of people that are enrolled in the program. And finally, on the spending side, in recent years, especially in light of enhanced federal funding and more flush and stable state budget conditions, we have seen states almost uniformly across the board expand eligibility and benefits and increase provider payment rates over recent years. H.R. 1, again, introduces kind of a new dynamic here in that it imposes payment limits, particularly on certain types of provider payments. And with that, we'll turn to the Medicaid managed care national landscape. So I'm not going to linger on this slide, but broadly there are 4 types of Medicaid delivery systems. Managed care is one of those. And when we're talking about a Medicaid delivery system, what we're talking about is how the Medicaid program is structured, who is responsible for certain program operations, whether that's paying providers or screening providers, conducting program integrity, conducting benefits eligibility, deciding what benefits are covered or not. And then how payments flow through that system. Do they go directly to providers from the state, or do they go and flow through managed care organizations? So managed care is one of 4 delivery systems, and the key difference between all of these is really whether the state retains control and over operations or whether it delegates some responsibility for operations and then exercises oversight over that. And the state legislative role is also consistent across delivery systems. So state legislatures have a role in deciding what delivery systems are in the state and how they're structured, who's covered in which delivery systems, what benefits are covered, and then obviously oversight, like you all are doing here today. So, when we're looking at the Medicaid managed care landscape, broadly, there has been an increasing trend towards managed care in recent years, and that's continuing to grow. So as of this year, 42 states use managed care, and Idaho enacted legislation this last year to transition to managed care in 2026. Managed care covers 75% of Medicaid enrollees nationwide, and these are predominantly children and expansion adults. So 80% of children and 80% of expansion adults are covered under Medicaid managed care. And payments to managed care organizations account for over half of Medicaid spending nationally, with the remainder of payments coming out into directly for fee-for-service benefits, such as hospitals, prescription drugs, all of that. So you might be asking, why 52% of spending, but 75% of enrollees? And that goes back to what it costs to cover different populations. So if you think to our per enrollee median spending, and children and non-disabled and young adults have the lowest per enrollee spending. If you think of managed care organizations traditionally covering those children and adults, they are going to have proportionally lower spending per enrollee. However, with that said, we have increasingly seen managed care organizations cover complex enrollees. So people with disabilities, including people with intellectual and developmental disabilities, and older adults. And we'll talk about this a little bit more later, but Florida recently in 2023 initiated a managed care pilot program for people with intellectual and developmental disabilities. And then finally, states use value-based purchasing and financial incentives to address quality. So when we're talking about value-based purchasing or value-based payments, generally what we're talking about is payment for value or outcomes instead of for the volume of services rendered. But in the managed care context, this comes up in a couple different ways. You can either have payment incentives for the providers themselves. So the providers are held to certain quality or cost benchmarks or outcomes, or you can hold the managed care organizations directly responsible for quality and outcomes through financial incentives. The financial incentives in the managed care context may look like value-based payment targets. So it tells the managed care organization you have to pay providers in a certain way to hold them accountable for quality, or it can come through financial incentives for the MCOs through capitation withholds, so withholding of a certain amount of premium payments, which is then returned to the MCO when they meet quality and outcomes and measures, and a couple other mechanisms that we'll talk about. So we're going to take a look at some state managed care kind of programs and what these look like, but I do want to highlight when you have seen one Medicaid program, you have seen one Medicaid program. This is both a joke and a truism. If you haven't seen 4 million Medicaid presentations in your life, this is in pretty much every single one of them. But it really is apples to oranges. Who is covered in Medicaid managed care? Who is, what benefits are covered? How your value-based incentives are structured, either directly in your provider payments. This all matters in terms of what you're going to see in different states. So I think it's important to look at this as a landscape of policy options and not a, so-and-so's doing it perfectly. Everybody's context is different. So on that note, let's dig into 4 state examples from Florida, Oklahoma, Oregon, and Texas. So starting with Florida. So historically, Florida has had a pretty long-standing managed care program. It rolled out statewide in 1984, so they have quite long-standing experience with this. And the current state is that they have 3 components to their managed care. They have a medical assistance managed care, which is children and most adults. They have long-term care and dental. So these are 3 kind of distinct managed care programs. But we also see that not everyone is in managed care. 87% of their population is in managed care, but there still remains 13%, at least as of 2022 data, that remain enrolled in a fee-for-service or state-operated delivery system. And as I mentioned, they did enact legislation in 2023 to create a pilot program for managed care for people with intellectual and developmental disabilities. So it looks like they may be looking to continue transferring more individuals into managed care. And they have, as we talked about, value-based purchasing payment targets. So these are requirements for what the managed care organization pays providers and how they pay providers. And then quality withholds for the plan as well. So we're going to walk through some of these managed care oversight tactics that they have. So on the value-based purchasing side, Florida established purchasing targets for both general, so the medical assistance and dental managed care organizations, to increase the level of provider risk for each contract year. So over each year of the managed care contract, the MCO is required to have a certain percentage of 10, 20, 30% of payments in a certain level of risk. The providers are supposed to assume a certain level of risk, and then that's required to increase over time, where providers are assuming increased financial risk over time. Additionally, there are incentives to drive improvement, but these incentives are more targeted towards the managed care organizations themselves and not just the providers. The plan incentives include a 2% quality withhold, which is then redistributed back to the plans based on their performance on the healthcare effectiveness data and information system measures. I might have gotten that acronym a little wrong. The plan incentives include preferred assignment or auto-enrollment of beneficiaries into plans that are high-performing on performance measures. And there's also penalties for poor-performing plans. So the lowest-performing plans are subject to corrective action, liquidated damages, enrollment freezes or enrollment algorithm reductions, and enrollment caps. So you can see both the carrot and stick approach in some of what Florida is doing. They have both the payment incentives and the quality withhold, as well as, and in preferred assignment of beneficiaries, as well as penalties. It's kind of double-ended with plans that perform highly, getting access to some of the benefits, and plans that perform, I think it's below 12% below some of the performance measures. You can start see some of these penalties kicking in on performance measures. Florida also has a quality bureau, which is responsible for managed care quality oversight, which includes measurement and improvement, research and evaluation of managed care plans, monitoring of clinical outcomes, oversight of prior authorization, and clinical consultation to the broader agency. And the Bureau here, the Quality Bureau, publishes annual health plan scores for all 3 types of plans and has a quality initiatives dashboard with goals related to potentially preventable events and improving birth outcomes specifically. And then finally, Florida has a compliance actions dashboard where it tracks the total number of actions and dollar amount by year for each managed care organization that they have corrective action plans, liquidated damages, and sanctions. So all of that is publicly available on a dashboard. Moving on to Oklahoma. So Oklahoma's got kind of an interesting delivery system history here. So in 2004, they moved from a managed care model, a very early iteration of a managed care model, into a primary care case management delivery system. They integrated behavioral health, and then in 2024, alongside the state's Medicaid expansion, they moved from primary care case management back to a managed care model. And they kept patient-centered medical homes, which had been integrated into their primary care case management model, into their managed care model. So primary care case management delivery systems and patient-centered medical homes tend to have some similar and overlapping features. So some of that was intended to be carried into the managed care model. We don't really have current data on their managed care population as of what the last data we have is 2022. They transitioned in 2024. But as of last state, 66% was in primary care case management. So we assume at least some percentage of that has moved over into managed care. And they have patient-centered medical homes, primary care payment reform. So this includes primary care spending assessments and spending targets that they're working towards, and some value-based payment targets for providers as well as their participants in the cell and gene therapy model, which is a CMS innovation model targeted towards prescription drugs, especially high-cost prescription drugs and cell and gene therapies. So their managed care oversight includes several different features, including the monitoring and oversight tool. So the state has contracted with a consultancy to develop a tool for the state's use to analyze all of the managed care reports that it receives from MCOs to assist in enforcing the state's contractual and regulatory requirements. And the intent here is for the consultancy to come in and help the state build and stand up their own tool for the state's continued use, not just for the state to consult that out temporarily. They also have a quality advisory committee, which has been tasked with developing the state's primary care spending target and analyzing primary care spending. The state also has value-based payment targets, so it's transitioning providers paid by managed care organizations into those value-based payment arrangements. And it also has some performance measures that are tied to those value-based payment targets, including the performance metrics are tied to decreasing emergency department visits for adults and children and increasing that primary care access. And the state also has targets that, cost growth targets that are specific to Medicaid that are set against the national health insurance expenditure growth rate. So the state reported that in fiscal year 2024, its cost growth target was below 5%, and that fiscal 24, actual cost growth was 4%, so it was within that target. And it's below 6% for through fiscal year 2029. So we'll have to see how the state performs on that. So one thing I'll note here is that while there are performance measures and cost growth targets that the state has set for the Medicaid program, it's unclear whether or not there's any financial risk for the managed care organizations tied to achievement of these measures. So like we saw in Florida, there's both incentives and penalties, carrot and stick. What we're seeing in Oklahoma is mostly carrot. So far as we can tell, or it's more focused on the provider population, not so much on the managed care organizations. Moving on to Oregon. So Oregon did comprehensive reform, Medicaid expansion, and transition to managed care organizations in 2012. One thing notable about Oregon's delivery system is that it's really managed care organizations kind of blended with what's called accountable care organizations. So these are managed care organizations that are held to population-based payment targets and global budgets. They're accountable and are required to be organized in a certain way and have certain governance structures. They're required and held to certain quality performance measures, and part of their payment in the global budget is tied to their performance on quality. So this covers acute, behavioral, and dental care services, and there are 16 coordinated care organizations in Oregon. Each is assigned to a specific geographic region, so they're not competitive with each other. They're each accountable for one particular region in the state. And over 90% of Oregon's Medicaid population is enrolled in Medicaid managed care in the CCOs. Oregon also has a wide range of value-based purchasing that they've done in the state, both in and outside of Medicaid, including primary care spending targets and payment reforms. They have those global budgets like we talked about. And they also have an all-payer claims database, which is a tool that states can use to evaluate spending in the program and other activities in the program. So on the managed care oversight side, Oregon also has a cost growth target. Theirs was set lower than Oklahoma's at 3.4% from 2021 to 2025.
All right, so you're watching and listening to Live Impact News on WCNT Plus. I'm Nick Serder. Right now, you're listening in General Assembly. So the Joint Legislative Oversight Committee is meeting to discuss Medicaid. So that's happening right now. But we want to come back here at home, and we want to step aside for just 2 minutes. We're going to take a break. We'll be back here in 2 minutes here on Live Impact News on WCNT Plus.